So good morning, everybody. I'll be presenting toric ICL in keratoconus. So this keratoconus, like we know, is a progressive thinning of the cornea that induces myopia, irregular astigmatism, and decreases the quality of vision due to monocular diplopia, halos, and ghost images. Generally, patients unfit for corneal procedures and intolerant to refractive correction by spectacles or contact lenses have been implanted toric ICLs in the past, either alone or with surgical procedures to correct the refractive error associated with keratoconus. And there are several reports which attest to the safety and efficacy of the procedure. Basically, the problem is the associated corneal higher order aberrations, which might have an impact on the final visual acuity. The purpose of this study was to report outcome of vision B4C toric ICL from the Star ICL company of Switzerland in keratoconus in 3 eyes. Inclusion criteria: patient age greater than 21 years, intolerant to contact lens either due to severe ocular allergy, VKC, should have undergone collagen C3R collagen cross-linking C3R at least 1 year prior to ICL implantation, and stable keratoconus on OBSCAN and dry refraction. The EC depth, which is measured from endo to anterior surface of the crystalline lens, should be greater than 2.8 millimeters. The Y-to-Y diameter measured on OBSCAN should be greater than 11 mm, and it should be correlated with digital caliper with a patient in supine position in a OR setup, and that is very important. Wide open angles. The peripheral retina should be normal or treated with laser photocoagulation when necessary, and distance visual acuity of 20/50 or better with glasses and a central clear cornea. No other ocular pathology. Exclusion criteria: patient age less than 21 years, mean K reading greater than 56. Patient with cataract, glaucoma, etc. should be excluded. Materials and methods: dry refraction, OBSCAN, harmful visual fields, gonioscopy was done preoperatively in all cases. All 3 cases of this implantation were done by a single surgeon, that is myself, Dr. Madhusmita, at Vasanayakar, Bangalore in 2013-14. The first patient was a 32-year-old female who had undergone C3R for both eyes for keratoconus 4 years back elsewhere in a Middle East country. UCVA was 6/36 OU with -8 diopter sphere, -4 cylinder at 50 degrees, improved to 612 N6 in OD, and with -8 diopter sphere, -2 cylinder at 140, improved to 612 parts N6 OS. Keratoconus was stable, confirmed from a previous OBSCAN and recent OBSCAN and dry refraction values. Both eye toric ICL was implanted from temporal clear corneal incision 3.2 mm under topical anesthesia. The next patient, that was the third eye of was a 30-year-old patient with keratoconus, UCVA CF counting 3 meters both eyes. He had undergone C3R 2 years 6 months back elsewhere. OD implantation, OD gave 66 parts in the OD was improving to 66 parts with -8 diopter sphere, -2 cell at 40 degrees. OS had dense corneal apical scar. So toric ICL was done in OD. This is the one of the implantation. In first patient, unaided vision was 69 parts. In 6 OU on first post-op day. Second patient OD on first post-op day was 66 -1. First patient completed a follow-up of 7 years, 6 months and doing well. Second patient has a follow-up of 5 years, 6-7 months and is doing well. There was no complication. So there are numerous studies that have documented the use of toric ICL for corrector is stable in these patients. To conclude, toric ICL is a good modality for visual rehabilitation in patients with stable keratoconus. These are some of the references. Thank you for your kind attention.
Yeah, thank you, Dr. Madhusmita. A wonderful series. One quick question is that I have seen that you are doing HVF 30-2 in all your patients before the ICL. So I wonder why is that? It was actually a kind of mandatory, that is also to prevent any medical legal complications if at all it arises in future. So just to be sure, like you can see that these cases have been done way back in 2000, like I have presented them, done in 2013-14. So when this was a comparatively very new technology, so there were very few reports, and just to make sure that you have not missed on anything, so that is the reason that you need to ensure that there is no glaucoma. Apart from clinically, you need to have clinical documentation also. Just like nowadays patients, even for a routine cataract extraction, many doctors do just a macular OCT, just to be sure, like you are seeing it, the retina surgeon sees it, just to be double sure, so that the patient doesn't, in future also, you are sure that there is no other problem from the eye of the patient that should deter you from doing the surgery if it is giving a good outcome to the patient. So that is the reason.
So are you performing HVF 30-2 in all your patients before ICL now?
Mostly, yes.
Okay.
And Dr. Madhusmita, one question is only one question, whether you would like to wait more than 1 year for stabilization of this refraction before you do implant ICL, because you said that in one case after 1 year you did it.
Yes, sir.
Most of the times the refraction changes for first 1.5 years to about 2 years also.
Not really. I mean, so I've been following cases for a long time, and many surgeons actually, just to ease up the process, they do it just even after 4 to 6 months. But I do not take that risk. I just after 4 to 6 months after surgery, there are rape reports also, and doctors keep telling that just after 4 to 6 months of C3R, people go ahead and do it. But I don't practice that. So it's a minimum time at least of 1 year. Again, you need to see the age of the patient. Say if it is a 20-year-old, not 20, I mean 22, 23-year-old, I would like to wait longer, but at least a minimum of 1 year. So most of these patients, like the first patient, this lady had actually come from a Middle East country asking for the surgical correction herself. And when I had done this was a very routine, new thing. So it is like 1 year is a minimum thing which is needed. And definitely in a 32-year-old patient or 35-year-old patient, it would not progress as much as compared to, say, a patient is coming at 23.
Okay.
Now, again, sex of the patient. So all these things, seeing the patient as a whole, I would go ahead and plan. But 1 year is a good enough time because surgeons are doing it even after 4 to 6 months. I do not recommend 1 month, but 1 year is good.